Hello and good morning. One more topic from respiratory system. Today we are going to learn that is CA bronchus, that is carcinoma bronchus. Carcinoma of bronchus. Okay. First we will see the etiological factors. This CA bronchus is commonest in men and it is second most common in women. Okay. The age group affected is over 40 years of age, and there are some predisposing factors like this cancer may occur in heavy cigarette smoking for many years. If a person is a heavy cigarette smoker for many years, that is the predisposing factor for CA bronchus. Next factor is exposure to other irritants like exposure to arsenic or exposure to radioactive substances, exhaust fumes, or sulfurated smoke or fog, some tarry particles from the road, and workers in chromate industry. So these are some irritants, they may cause CA bronchus. Okay, so these are the predisposing factors. Now we'll see the pathology of CA bronchus. The pathology includes three microscopic types. First one is main bronchus tumor. Second one is peripheral tumor, and third one is pancreas tumor. Okay, so first is main bronchus tumor. This main bronchus tumor occur in main bronchus or one of its primary or secondary divisions. So majority of this tumor arises in main bronchus, that is of its primary or secondary divisions. Then whenever there is bronchial irritation, that bronchial irritation will lead to bronchial ulceration, and because of bronchial or ulceration there will be bronchial obstruction. Okay, how the pathology grows, that is first there will be bronchial irritation, that may be because of various irritants that we have seen in predisposing factors like there are some irritants like arsenic or radioactive substances or some fumes or smoke or fogs, etc., or the persons who are working in chromate industry. So these are the irritants, bronchial irritants. These bronchial irritants or smoking, these bronchial irritants will lead to bronchial irritation. Because of that irritation there will be bronchial ulceration, and then thereafter there will be bronchial obstruction, and that will lead to tumor formation, that is obstruction, bronchial obstruction. This cancer or this, when the main bronchus tumor is present, then that is visible on bronchoscopy. So when you do bronchoscopy, this main bronchus tumor will be visible. The next one is peripheral tumor. It is less common and it arises from smaller bronchi. Okay, the first one was arises from main bronchus, but this peripheral tumor that will arise from the small bronchi, and it is visible on fiber optic bronchoscope, and it rarely causes secondary lung changes, and some peripheral tumors may be discovered at routine radiography also. So this is peripheral tumor. Once again I will repeat, this peripheral tumor is less common. It arises from small bronchi. It is visible on fiber optic bronchoscope, and it rarely produce secondary lung changes, and these tumors, peripheral tumors, may be revealed on routine X-ray, routine radiography. And then third one is Pankos tumor. It arises at apex of lung. This Pankos tumor arises at apex of lung. It will invade bronchial plexus, sympathetic chain. It will also invade upper ribs and adjacent vertebra, and that will produce Pankos tumor. This lesion is very distressing and causes intractable pain, which is very difficult to relieve, and growth is slow. So Pankos tumor is a peripheral lung cancer. It arises at apex of lung, okay, and this tumor invades bronchial plexus, the sympathetic chain, upper ribs and adjacent vertebra, and this will produce Pankos tumor. This tumor is very distressing. The lesion is very distressing and it will cause intractable pain, which is difficult to relieve, and the growth of this tumor is very slow. So these are the three macroscopic types, the pathological types of CA bronchus. First one is main bronchus tumor, peripheral tumor and Pankos tumor. So main bronchus tumor will include only main bronchi with primary or secondary bronchus. The peripheral tumor will include the small bronchi, and the Pankos tumor will include or it is present at the apex of lung, and that will invade, this tumor will invade the brachial plexus, and sympathetic chain, bronchial plexus, sympathetic chain, upper ribs and adjacent vertebrae. This main bronchus tumor is visible on bronchoscopy, while this peripheral tumor is visible by fiber optic bronchoscope. So these are the three types in pathology of CA bronchus. The next we'll see the histological types. There are three histological types. First one is squamous cell, that is called as epidermoid carcinoma, squamous cell carcinoma. This is about 50%. Then second one is anaplastic carcinoma, that will include small cell, or it can be also called as oat cell carcinoma, and large cell. The small cell is about 15% and large cell is 5%. And last one is adenocarcinoma, which is of 20%. So these are the three histological types: squamous cell carcinoma, anaplastic carcinoma, which includes small cell and large cell, and third one is adenocarcinoma. In anaplastic carcinoma, this anaplastic carcinoma is poorly differentiated. It has rapid growth and it has early metastasis, and it is very common in young individuals, the anaplastic carcinoma. Then we will see the spread of the growth, how this CA bronchus spreads. So first spread is by direct spread or direct extension. The direct extension is into mediastinum or into pleura, in the chest wall or in pericardium. So this, if the person is having so spread of this carcinoma is into mediastinum, pleura or chest wall or in pericardium. Next one is by lymphatics. So by lymphatic system, first the hilar lymph nodes are affected. Then the spread will be to the paratracheal chain, Then upper nodes of chain are mainly affected. Through these upper nodes of chain, the spread will be continue with deep cervical lymph nodes, and these deep cervical lymph nodes can be detected by digital palpation, which are deep to the insertion of sternomastoid muscle. Some supraclavicular lymph nodes may be involved, and there may be contralateral spread that may occur from left lower lobe to right paratracheal nodes. So this is the lymphatic spread, and last one is by bloodstream, that is to liver, to the brain, then to the bones. Bones will include ribs, mostly ribs, vertebra, pelvis, and long bones. It may spread to adrenal glands and skin. So this is the spread of bronchus. The direct spread, directly it may spread to mediastinum, pleura, or chest wall, or pericardium. Through the lymphatics, it will spread to, from hilar lymph nodes, it will spread to paratracheal chain. From paratracheal chain, from the upper nodes of that chain, they will continue with deep cervical nodes. So from paratracheal chain, the growth will spread to deep cervical nodes, and when the deep cervical lymph nodes are affected, then they can be detected or palpated by digital palpation deep to the insertion of sternomastoid muscle. Then the supraclavicular lymph nodes may be involved, and there may be contralateral spread that may occur from left lower lobe to right paratracheal nodes. And last one is blood spread. It may spread to liver, to the brain, to bones like ribs, vertebra, pelvis, or long bones. Then it may spread to adrenal glands and skin, etc. Now the clinical features of CA bronchus. The symptoms present due to first by primary tumor, or by secondary deposits, or by one of the adrenal endocrine related system, or combination of any above three. So the symptoms or the clinical features are because of the primary tumor. Symptoms may be because of primary tumor, or they may be because of secondary deposits, or by involvement of endocrine gland, or endocrine related symptoms are there, or the symptoms are may be because of combination of any of above three. So first we'll see about the primary tumors. When there is primary tumor, there will be cough with sputum, that is for more than 2 to 3 weeks, or change in the character of chronic cough with chronic bronchitis. Then there will be hemoptysis, that is blood in the sputum, and dyspnea, which is due to partial or complete bronchial obstruction. There may be chest pain and wheeze, which is less common. Then any patient over 40 years with these symptoms, that patient must be investigated to exclude bronchial carcinoma, and also patient with slow radiological resolution of pneumonitis or pneumonia, that should be investigated. So these are the three most common symptoms that occur in primary tumor, that is cough with sputum for more than 2 to 3 weeks, Then change in character of chronic cough with chronic bronchitis, hemoptysis and dyspnea, due to which dyspnea is due to partial or complete bronchial obstruction. These are the three common symptoms: cough, hemoptysis and dyspnea. Then the patient above the 40 years of age with above symptom must be investigated to exclude the carcinoma bronchus. Then the first symptom may be due to invasion of mediastinum, and that will cause, if there is pressure on SVC, that is superior vena cava, then that will causes superior vena cava obstruction. If there is pressure on recurrent laryngeal nerve, that will cause hoarseness of voice. Then if there is pressure on trachea or main bronchus, that will cause stridor, and pressure on esophagus will cause dysphagia. So the first symptoms may be due to invasion of mediastinum. If the mediastinum is invaded, that may cause some symptoms, like pressure on superior vena cava will cause superior vena cava obstruction. If there is pressure on recurrent laryngeal nerve, then that will cause hoarseness of voice. Or if there is pressure on trachea, if that tumor will cause pressure on trachea or to the main bronchus, then that will cause stridor. And if there is pressure on esophagus, that will cause dysphagia, that is difficulty in swallowing. So these are the clinical features that occur in primary tumor. Okay, once again I will repeat the three common symptoms of primary tumor, that is cough, which is for more than 2 to 3 weeks, hemoptysis and dyspnea. And the first symptom may be due to invasion of mediastinal structures. Okay, then second one is secondary deposits, that is metastasis. So secondary deposits may be, as we have seen in spread of growth, that it may spread to various other organs of the body. So secondary deposit, if brain is involved, then there will be headache and vomiting. There may be epileptiform fits, and there may be weakness of limb leading to paralysis. So when the brain is involved, when there is metastasis that goes up to, or when there is secondary deposit in the brain, then there will be headache, vomiting, or epileptiform fits, or there may be weakness in the limbs and paralysis. Secondly, when there is bone pain, or when the bones are involved, especially vertebrae or pelvis or long bones, there will be bone pain. Then if skin is involved, then there will be skin nodules that are formed. Then lastly, the endocrine related symptoms. The endocrine related symptoms are, first one is osteoarthropathy, that includes arthritic symptoms or finger clubbing. There will be arthritis or finger clubbing is present. Then the neuropathy may be present. Then there will be, that is carcinomatous neuropathy. Then abnormal hormonal secretion may be there, and that will cause hypokalemia. That will lead to, because of hypokalemia, there will be muscle weakness. If there is hyponatremia, then there will be water retention, and if there is hypercalcemia, then there will be confusion and drowsiness. Some other symptoms like gynecomastia and Cushing's syndrome may also be present when the endocrine gland is involved. And general features like anorexia, malaise, or loss of weight, they are also present. So these are the clinical features of CA bronchus. These symptoms are because of first primary tumor, when there is primary tumor, or the symptoms may be because of secondary deposit to various organs like brain, bones, skin, or endocrine glands. And the third one is because of involvement of endocrine gland, that is endocrine related symptoms. Then investigations that has to be done in CA bronchus. So first investigation is you have to do first chest X-ray. That will include lateral view also. There will be collapse and consolidation of segment or lobe or lung, whole lung. Then there may be a cavitary lesion may be present. So on X-ray chest, that will also include lateral view also. You have to do lateral view also. Then it will include collapse or consolidation of the X-ray chest will show collapse or consolidation of segment or lobe or whole lung. Then next investigation is bronchoscopy. It may be rigid or fiber optic instrument is through the rigid or fiber optic instrument it is done, and it is to obtain histology by biopsy or bronchial washings. And bronchoscopy is also done to assess operability. Operability. Then third one is cytological examination. Cytological examination of sputum that will reveal malignant cells in about 60% of cases. The next investigation is needle biopsy of peripheral lesion under radiographic control, and that is for histological diagnosis. Needle biopsy of peripheral lesion under the radiological control. Next investigation is barium swallow, the mediastinal for the mediastinal glands and esophageal involvement. You have to do the barium swallow. Then tomography, that is CT scan. It will show mediastinal lymph node involvement. Then for secondary deposits, you will have to do liver, brain, and bone scanning. Then you will also have to do whole body CT scan or supraclavicular lymph node biopsy or mediastinoscopy. These investigations they are done according to the symptoms. Okay. The diagnosis of the CA bronchus, it is a positive histological diagnosis at bronchoscopy in about 70% of cases. Then CA cell in sputum or pleural fluid in some cases. Then in about 25% of cases only presumptive diagnosis is made, and in these cases exploratory thoracotomy is advised. So diagnosis include a positive histological diagnosis, and bronchoscopy is available in about 70% of cases. whilst malignant cell in the sputum or pleural fluid provide positive evidence in some of the remaining cases. And in about 50% of cases, however, only the presumptive diagnosis can be made, and these causes must have an exploratory thoracotomy if fit. In the unproven case, a carcinoma is most likely to be confused with chronic suppurative pneumonia or lung abscess or solid tubercular lesion or benign tumor. So you will have to differentiate with these cases. You have to do the differential diagnosis with chronic suppurative pneumonia, with lung abscess, solid tubercular lesion or benign tumor. So careful consideration of the history and response to antibiotics will often provide the strong circumstantial evidence against carcinoma, while tomography may be helpful in doubtful cases. So we have to take a careful history as well as response to antibiotics and the investigations that will help to diagnose a case. Then lastly, treatment, that is surgical removal of tumor is the treatment for CA bronchus, that is removal of tumor or removal of regional lymph nodes and preservation of normal lung. The aim of this surgical treatment is it must be adequate removal of primary tumor and regional lymph nodes, but with preservation of as much normal lung tissue as possible. So treatment, once again I will repeat, treatment includes surgical removal of tumor. There is another treatment that is available, that is radiotherapy. Radiotherapy is only very rarely curative and it is cytotoxic treatment. That's why it is palliative only, it is not curative. So curative treatment is surgical removal of the tumor. But when you do surgical removal of tumor, the aim of that operative procedure should be to remove the primary tumor and the regional lymph nodes, but with preservation of as much as lung tissue as possible. So the treatment is pneumonectomy or lobectomy. It depends upon how much involvement in the lung or the bronchus that is involved. So the surgical treatment is pneumonectomy and lobectomy. Radiotherapy is rarely curative, it is palliative treatment, and cytotoxic treatment is also palliative treatment. So that this is all about the CA bronchus. We will take a small review of CA bronchus once again. This CA bronchus is very common in men above 40 years with heavy cigarette smokers, with exposure to various irritants like arsenic, exhaust fumes or sulfurated smoke or fog or tarry particles from road or workers in chromate industry. Then there are 3 pathological microscopic types like main bronchus tumor, peripheral tumor, and pancreas tumor. So the main bronchus tumor will arise from main bronchus with primary or secondary bronchus involvement. Peripheral tumor is less common and it involves small bronchus, small bronchi, and pancreas tumor will be present at the apex of lung, and this tumor will involve or invade bronchial plexus, sympathetic chain, upper ribs, and adjacent vertebrae also. Then histologically also there are three types, that is squamous cell carcinoma, which is about 50% of cases. Then anaplastic carcinoma, that includes small cell carcinoma and large cell carcinoma. Small cell is about 50% and large cell is 5%. And third one is adenocarcinoma, which is of 20%. This anaplastic is it is poorly differentiated tumors exhibiting rapid growth and early metastasis and common in youngs. Then spread of the CA bronchus, it includes spread to the direct spread, that is to mediastinum, pleura, chest wall, and pericardium is involved. Then lymphatic spread from hilar lymph nodes, the paratracheal chain is involved, and the upper nodes from paratracheal chain, which is continuous with inferior deep cervical lymph nodes. So the deep cervical lymph nodes may also involved, and you can palpate these deep cervical lymph nodes by digital palpation deep to the insertion of sternomastoid muscle. Then other supraclavicular lymph nodes may also involved, and some contralateral spread may be there from left lower lobe to right paratracheal nodes. And third spread is through blood. When there is spread by through the blood, then liver, brain, bones, and adrenal glands and skin may be involved. Then clinical features. These symptoms or clinical features are due to primary tumor or by secondary deposit, or endocrinal symptoms may be there. So the primary tumor, when there is primary tumor, the three common symptoms, that is cough with sputum for more than 2 to 3 weeks, then hemoptysis is there, and dyspnea is there. And other symptoms are maybe because that tumor may involve the mediastinal structures, that will cause pressure effect on the mediastinal structures, and therefore some symptoms will appear like severe obstruction or hoarseness of voice or stridor or dysphagia. Then next one is symptoms or clinical features due to metastasis. When the brain is involved, there will be headache, vomiting, epileptiform fits or weakness in the limbs and paralysis. When bone is involved, there will be bone pain, and when skin is involved, there will be nodule formation. And the last one is endocrine related symptoms, like there will be arthritis, finger clubbing, then carcinomatous neuropathy will be there, and some symptoms because of abnormal hormonal secretion, and those are because of hypokalemia, that will cause muscle weakness, hyponatremia will cause water retention, and hyperkalemia, calcemia, that will lead to confusion and drowsiness. And some other endocrine related symptoms like gynecomastia or Cushing's syndrome, they are also present. And general clinical features like anorexia, malaise or loss of weight, these are also present in CA bronchus. Then investigation that has to be done, they are X-ray chest, bronchoscopy, cytological examination of sputum, needle biopsy of peripheral lesion under radiological control, barium swallow, tomography, whole body CT scan, then liver, brain and bone scanning you have to do, then supraclavicular lymph node biopsy and mediastinoscopy has to be done. Then diagnosis of CA bronchus is with, in about 70% of cases, is by bronchoscopy. 25% cases, in 25% of cases only the presumptive diagnosis is made, and other cases as a CA cell in sputum or pleural fluid may be seen in some cases. The differential diagnosis is chronic suppurative pneumonia, lung abscess, solid tubercular lesion, and benign tumor. So you have to take the whole detailed history of the patient along with investigation will reveal the diagnosis. The treatment for CA bronchus is surgical removal of tumor. That is, you have to remove the tumor with removal of regional lymph nodes, and you have to preserve the normal lung tissue as much as possible. Then you have to do pneumonectomy or the surgical procedure, that is pneumonectomy or lobectomy. The radiotherapy is rarely curative, and this radiotherapy and cytotoxic treatment, these are the palliative treatments. So this is all about the CA bronchus. Now you have some homework, that is I will give some 2 marks question. You have to solve it, okay, and post me on my WhatsApp account, okay. So first 2 mark question is pantaloon hernia. Second question is pre-vesical hernia. The third question is 2 signs of strangulated hernia. Fourth question, what is strangulated hernia? Fifth one is, what is intravesical prostatic collar? And sixth one is, what is TURP? Sixth question is, what is TURP? Seventh question is Pancoast tumor. Seventh question is Pancoast tumor. The eighth question, the etiological factors of CA bronchus. Etiological factors of CA bronchus. Next question is the 3 most common symptoms in primary tumor of CA bronchus. I will repeat again, 3 most common symptoms in primary tumor of CA bronchus. So these are the 2 marks question. You have to solve it and post me. Thank you.